Welcome, everybody. Welcome to the webinar on organizing for Ontario health teams. Really happy to have everybody back here today. Please enter into the chat and let us know who you are by introducing yourself and which organization you're from. If you're from an OHT, let us know which OHT, and otherwise, please, let us know what your organization is or your chat. So now I can see, come in and start to watch these. I see Melissa, Monroe Ross, Claudia from Western New York, Ian Mass, Stephanie from, Steve from Rainy River, Stephanie from Western New York, Niagara Ontario Health Team. As a group, Tara McKendrick is there, Lisa Sullivan, Katie from Windsor, Veronica from Kawartha Lakes, welcome. And Chantel Marshall, sorry, I'm Chantel, nice to see you from Spectrum. Marilyn from VON, Trish from OHT Northumberland, Teresa from Guelph Wellington, lots of people, 140 people in now. We're expecting a couple more today. It's a popular topic, I think. So we'll just allow everyone to keep coming in. Danielle from Peterborough, Angelica from the Center for Effective Practice, welcome. Welcome, Joelle Plourde, and Judy Porteous from Osteoporosis Canada. Okay, about 150 on now, many more still to come. This is a very popular webinar today. We want to begin by acknowledging, and this is a particularly important week and notable week with our National Day on Friday, wishing to acknowledge the land on which the University of Toronto operates. I'm speaking to you from here. And for thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, the meeting place is home to many Indigenous peoples from across Turtle Island, and we're grateful to have the opportunity to work on this land. I am grateful to have the opportunity here, and I welcome you in your regions and in your lands to acknowledge the land that you are joining us from today. And I particularly look forward to Friday, thinking about both reconciliation, remembrance, and also in the spirit of true partnership and sharing. We're going to start here just with a little check-in because it's always fun to do this. And so I would just ask you if you could just check in and let me know, let us know here if you've joined us for an HSPN webinar before. We know that many of you are back. And we're anticipating this coming up, but also a good number will be new. We have almost 200 people online now. So coming in, please just click one of those two buttons and let us know if this is your first time. Okay, and slow down a little bit. So for those that are coming and going to be able to respond here, here you go. And we'll share these results out so everyone can see that about almost 80% of people are back again, and welcome back. And then for about 30 or about 20% of the people who responded here, this is your first event. So I think you're in for a bit of a treat, and you'll have a little bit of history here because we're referring back to earlier results as well. So welcome to the webinar today. And let's just highlight that we previously had a webinar's materials related here, and I encourage you to check onto our website to go pull some of these prior reports. So we did, today we're going to talk about our survey, the Organizing for Ontario Health Teams, and we have two prior reports from the first two cohorts. Both reports are available bilingual English and French. The first one was produced in March 2020 with cohort 1, and then a year later with cohort 2 in 2022. We also had some early insights and some infographics and a webinar in September 2020 with that cohort 1 results. And as you're trying to understand where we're at now compared to where we were before, I encourage you to go back and have a look at those prior reports. Today, it is my absolute pleasure to have both Ruth Hall, a co-lead here in the OHT evaluation, and also some commentary from Anne Wojtak, who is the lead for the East Toronto Health Partners, and also works with the International Foundation for Integrated Care and other partners internationally, thinking about how do we come together, create networks and around shared purpose. And so we're really happy to have Anne commenting a little bit today. Ruth, however, will be the lead through showing us some of the preliminary previews of results. Due to popular demand, many of the teams have received their own results already. Well, all the teams got a copy of them. I don't know how widely they've been disseminated yet, but it was a very crude, just a data pack. Our full report will be coming out towards the end of October, but people were clamoring and saying, you're going to show these results. Could you please let us know what our results are so we can follow along a bit better? So we've done that, and I encourage you to keep an eye on that. But let me just ask, for people who have been around now, maybe they haven't seen these results yet. So for cohort 1 and 2, we surveyed in 2020 and 2021, and now so for the first cohort, it's 2 years out. For everybody in the audience, I'm just wondering, and these, we haven't gone into all of the details of what the survey is about, but the organizational survey asks about leadership, shared vision, readiness for change, a lot of the supports and capabilities that OHTs will need to advance and implement their models of care. So compared to 2 years ago, how do you think the spirit is around OHTs now? So I'm going to pop up this poll and share it out. And if you could let me know, what do you think you would expect the results to be? Do you think they'll be more positive and enthusiastic about the OHTs, about the same, or whether maybe you think that it's been difficult to sustain the same level of enthusiasm, and the scores may actually be a bit down. So, so there we have, and I know everybody won't be super familiar, so everybody may not respond in. We are up to almost 250 people with us now. I see a couple of the late joiners. Do feel free, the late joiners as well, continue to type into the chat and introduce yourselves, please, into the chat. Okay, so for those who are going to answer, I think we have now. And so here are the results. It's a pretty even split there, Ruth. That's pretty interesting. About a third of people thinking that things would be better, about a third thinking they'd be about the same, and actually only a quarter, so slightly less, thinking that there would be the results would be down a little bit. Well, we're going to find out. Really looking forward to that today. So Ruth, without further ado, I think I will take this poll down and put it on to the next slide. And you can just tell me when you want me to move along the slides. Okay, Ruth?
Yeah, thanks.
Welcome.
Thanks, Walter. Welcome, everybody. And have the privilege of sharing with you the early results from the 2022 Organizing for OHT survey. Walter mentioned that this was second time around for cohort 1 and cohort 2, and the first time for cohort 3 to be able to complete this survey. Next slide. So just to remind everybody, this is a 42-item survey that's an abridged version of leader and provider surveys that were part of the context and capabilities for integrated care toolkit. So that's CCIC toolkit. And it measures 10 validated domains that are considered to be important for working together as an integrated care team to improve patient and population health outcomes. It's most of the survey questions are a 5-point Likert scale, and for all the items except for one question, which was a 4-item response category, and that was to use to describe your organization's attitude towards change. And then we had an open question for number 42. Just to say it is abridged, that toolkit surveys was over 100 items, so we trimmed it down significantly. Next slide. So what we did for this time around was the same approach we have done for the other two, that we asked for the content information for one representative who was most involved in the application process for each signatory organization on the original OHT applications. And for cohort 1 and 2, because of the time that had lapsed, we wanted to verify that those organizations and or individuals in the original application were still involved, and let us know if there were any new organization or individuals that were very involved with the OHT work at the time this survey was administered. Next slide. So our response rate was overall 46%. Not that great, but not too bad. We had over 1,400 individuals, contacts that were considered to be most involved in the application process. And the survey was sent out between March and May, so a longer period of time than we had in previous surveys. And not surprising with the COVID, I don't know what wave it was at that point, but we were still in COVID. And we had 653 individual responses. That gives us our 46% response rate. This is down from cohort 1 and cohort 2, which had individual response rates about 60%. And when we look at the average OHT response rates, that was 54%. And again, this is, and it ranged from 15 to 83. And this also has dropped. It was much higher for cohort 1 and cohort 2 in the 70% average OHT response rate. This time around, we only had 4 OHTs that achieved more than 80% response rate compared to almost half of the OHTs in cohort 1 and just about a quarter for cohort 2. Next slide. And, you know, this is for leadership, and we did get 66 response rate, 6%, 66% or 2/3 of our respondents are from the leadership, but we did have patients and caregivers and clinicians or physicians as well responding to the survey. Next slide. And in terms of organizations, almost 60% of the organizations represented in the survey were from the community, and that's the community support services, community health agency, and home care. But we did have a good representation from the primary healthcare practice sector. Next slide. So in terms of our results, remembering we have 10 domains and we have, you know, a 5-point Likert scale. So we calculate the mean score for each of those domains. And our top domains were commitment to improvement. And that's, you know, we have a common vision on how we're going to improve the integration of care, and we agree to share responsibility for achieving improved patient outcomes. And also we had team climate rating pretty high, and that's getting at things like we're in this together attitude, and we take time that's needed to develop new ideas. And it also asks about the extent that the respondents felt their OHT's objectives could actually be achieved. And then we had administration and management, as well as roles and responsibilities that were in the top as well. So that administration and management was getting at things around communication among the members and organizing activities, meetings, projects. And roles and responsibilities is asking whether you felt that you understood the role that your organization played in responsibility for a local population, and your role in coordinating the care for the population. Next slide. So our lowest domains were, not surprisingly, financial and other capital resources. So that's money and tools and technology that we're asking about there. and then followed by clinical functional integration. And that's talking about tools. You share those tools for clinical coordination, and you share clinical information across partners. And shared vision in the non-financial resources also rated lower, as low. And shared vision is about developing goals that are widely understood and supported among the members. And you respond to the needs and problems of the community, and you include the priorities and views of the people affected by the OHT's work. And in terms of the non-financial resources, this is getting at the perception of your skills and expertise to work effectively, and data and information, and your ability to identify your target population and deliver those interventions. Okay, so those high and low domains really are similar to what we saw in cohort 1 and cohort 2, just that those mean scores have dropped in comparison to earlier release of the survey. Next slide, Walter. We didn't talk about leadership coming up there in the top or the lower domains. It's sort of middled. But it's important to look at some questions within that leadership domain, because it's talking about trust. And here, the question about whether your leadership, you felt the leadership was very good or excellent at fostering trust, was under 60%. So only 57% of the respondents felt that their leadership was very good or excellent at fostering trust. And in terms of whether the leadership was very good or excellent at creating an environment where differences of opinion could be voiced, that was just over half of respondents. These rates are lower, much lower than what we saw in cohort 1 and cohort 2, where it was over 60%, and then in cohort 1 it was around 71% felt that their OHT leadership was very good or excellent at fostering trust. Next slide. And it was also important to ask about the organization the respondent was representing, what their attitude was, the organization's attitude was towards change. And it's encouraging to see that almost 3/4 of the respondents felt that their organization or practice setting was innovative or open to change. And that is encouraging, given this is a transformational change that is trying to happen in our healthcare system. Noting that in previous cohorts, this response of considering their practice or their organization innovative or open to change was over 80% in previous cohorts. Next slide, Walter. So this is where I'm going to begin to look at the domains by cohort. So you can see the patterns that have emerged when we look at cohort. So the overall results, and by cohort, looking at the mean score by domain. Next slide. So how this is oriented is that we put the domains with the highest mean score at the top and the lowest mean score at the bottom. So as we move down, you can see the mean scores drop. And the gray bar is the 90th percentile among the OHTs, and the black bar is among the 51 OHTs, what was the mean score, and that was what was represented in that radar chart. And the red bar is for cohort 1's mean score, the blue is cohort 2's mean score, and the green is cohort 3's. Next slide. And then we wanted to look at, it's sometimes interesting to look at the proportion of the respondents that are selecting those top 2 boxes. The wording may change depending on the question, but it's sort of thinking about excellent or very good or strongly agree or agree. Next slide. And here we see the pattern is very similar in terms of the top rated domains. And we can see that the overall, again, is the same coloring pattern here. And the red is cohort 1, and blue cohort 2, and green cohort 3. The pattern that's pretty clear is that cohort 1 seems to be much higher compared to cohort 2 and cohort 3, and except for in the non-financial resources domain, where cohort 2 performs much higher than cohort 1 and cohort 3. Next slide. Next, we're going to look at how the results changed. This is only looking for cohort 1 and cohort 2 by domain, looking at the mean scores at time 1 versus time 2. And this is rating the domain by the least amount of difference between, or sorry, the improvement, so the greatest improvement at the top, down to the greatest decrease at the bottom. So the dark red bar is time 2, the most recent survey, and the lighter bar, blue or green, blue or red, sorry, being time 2. So, and cohort 1 on the left side and cohort 2 on the right side. So we can see that cohort, compared to cohort 1, the decrease in shared vision was much greater relative to the other domains. For cohort 2, there was a bigger drop. So shared vision was ranked 5th in cohort 1, and meaning that in change, versus ranked 8th. So it had a bigger change in cohort 2. And in terms of team climate, compared to cohort 1, the decrease in team climate was less in cohort 2 compared to cohort 1, because team climate in cohort 2 was the 4th. So it had the 4th least amount of difference between time 2 and time 1. Whereas in cohort 1, it was ranked 7th. So it had greater change. Next slide. So this is looking at the same approach, only looking at the top 2 boxes, the respondents selecting the top 2 boxes. And they, compared to the mean scores, the 2 cohorts are similar in terms of the rankings of the domains. We didn't see that as much similarity when we looked at mean scores, but we see more of it here in the top 2 boxes. And in particular, cohort 1, we see bigger differences in the ranking of the domains when we look at the proportion selecting the top 2 boxes for shared vision. It is down at the bottom for both cohorts, so there's similar ranking. They had the biggest drop, but it was much larger for the cohort 1 than it was for cohort 2. Next slide, Walter. And here we're going to just look at what is, I've talked about changes that have happened, things have dropped, and we're looking at meaningful change. And so we did some calculations for those domains and looking at the difference between time 1 and time 2, and what did it look like in terms of meaningful change. Next slide. So how we defined a meaningful change is the difference between the mean score from time 1 to time 2 is greater than or equal to half of a standard deviation. So this is commonly used in survey quality of life literature. So it was a rule of thumb that we applied here to see where are there meaningful differences. So what the purple is showing you the number of OHTs where we saw a meaningful decrease compared to at time 2 compared to time 1. And the yellow bar shows where the number of OHTs that had no change. And the turquoise is the number of OHTs that have a meaningful improvement. And quite strikingly, you see that the financial and other capital resources had a large number of OHTs, 26 or almost 60% of the OHTs where there was a meaningful increase. And although it did rank the lowest domain, it was the domain where we saw the greatest meaningful change compared to time 1, which is encouraging given the resources that have come out from the ministry and OH over the last year and a half or so. Concerningly, we see that this readiness for change suitability category, and that's getting at the questions that I think my organization and practice will benefit from this change, and in the long run I feel it's worthwhile for the organization to adopt this change. This is where we saw the largest, almost 90% of the OHTs saw a meaningful decrease in their agreement with those statements. Next slide, Walter. So did any OHT show an increase across all domains or most domains, given this sort of sad news we're sharing? And we did, yes, we did. We saw one OHT had an increase in the proportion or percentage of respondents selecting 4 or 5 on all the domains. And we had 3 OHTs that saw an increase in the percentage of respondents selecting 4 or 5 on 7 out of the 10 domains. So there are some shining lights there. Next slide. So just to sort of wrap up with conclusion and lead into some discussion, we hope, I'd just like to quickly summarize. Walter, next slide. So our domains that rated the highest in terms of measuring capabilities or factors needed to deliver integrated care is the area of commitment to improvement, so that we are in this together. And team climate, we're willing to take the time to think about the work that we do. Administration and management, and readiness for change. And in terms of the leadership ratings about fostering trust, because that is essential, and creating in a safe environment, they were rated moderately. So 3.6 and 3.4 out of 5. And as I presented earlier, not just over 50% of respondents felt that their OHTs had this climate. Next slide, please. And their lowest domains were the financial and other capital resources, clinical functional integration, a shared vision, and our non-financial resources. So as I mentioned, there's little change in what are considered the highest rated and lowest rated domains from our previous release of the survey. And cohort 1 had higher means compared to cohort 2 and 3, except for financial and non-financial domains. Where cohort 2, missing them 2 there, had higher scores. And cohort 3, not surprisingly, consistently had lowest mean scores, and there was not one OHT that had over 80% of their respondents selecting the top 2 boxes for any of the domains. Next slide. And compared to earlier surveys, all domains had lower mean scores and a lower proportion of respondents selecting those top 2 boxes. And readiness for change and shared vision saw the largest decreases in the proportion of respondents selecting those top 2 boxes. And as well, these were the 2 domains that saw the largest number of OHTs with meaningful decreases in their scores from time 1 to time 2. Next slide. And just to share with you some stats, just basic stats up here to lead into the comments. We see this is the domains down the left, and we've colored them based on where we feel like the magenta color are domains that are likely going to need support across all the OHTs, because there's little between a small amount of variation between OHTs and their scores. The bolded domains are representing those areas that there are some OHTs that are going to need more support in those, and the others don't need as much. And that is reflected in a higher between team variation in that last column. Next slide. So that's, in general, some domains had high consistency across teams. So that's showing you there's a little variation. And that is in the resource domains, financial and non-financial, as well as readiness for change and clinical functional integration. And all OHTs are going to need that. And then other domains, there's more variability. So there'll be some that need help with this notion of commitment to improving administration and management, as well as leadership and shared vision. And that's probably around those OHTs that have lower mean scores on those domains. Next slide. So in summary, just over half of the members of OHTs rate their leadership's ability to foster trust, respect, and create a safe environment highly. Almost 3/4 of OHT members feel that their organizations are innovative and open to change. So that's encouraging. However, there are a few OHTs, 8, that out of the 51, where 80% or more of the respondents moderately to strongly agree they share a common vision on how to improve the integration of care and agree to share responsibility for improving patient outcomes. So that's getting at that commitment to improvement domain. Next slide. Okay. So in looking through these results, I ask you, do you feel that the OHTs are on board for this transformational change? And are the differences in scores a result of OHT membership has changed dramatically? We did collect that information, and we will be looking at that in the further analyses. You know, did COVID sidelining initiatives or waning enthusiasm post-COVID contribute to these results? Thanks.
Hey, wow. So that was it's a lot of information at a pretty high level. Ruth, appreciate you're taking the time to walk us all through those results. You know, you and I have been looking at these for I guess so a little over a month now, a month or two, and since we were actually able to compile them and trying to understand the sense of them, and I'll say, you know, we'll have, you know, you mentioned a more fulsome report coming out, and people will be able to see granular data within their own OHTs over time on each of these domains and dimensions, and see some of those. So I think that's really promising. And understand that everyone will also have the chance to see item levels. So all of these today, you put up a couple of key items, and I might ask you why you chose those ones in just a second. But there are, you know, certainly item level changes, and so everyone is not moving in the same direction at the same time. And I think it will be important for teams to understand where they're at, where they've held ground, where they maybe have advanced a little, and where they've seen some slippage. Do you, like, how did you pick out the few items? I think you had some around kind of shared leadership, trust.
Well, we know that the trust is an essential underpinning element for successful partnering to better deliver integrated care, according to the literature, especially when you've got multi-organizational systems, like system care and multi-organizations coming together to try and work as one team. And that also would support understanding whether the leadership does create an environment where those different voices can be heard.
Yeah, and I think, every time, sometimes maybe the membership changes, or some, as Raham, I think, asked about whether we tracked it with the same people or not, but there's a general phenomenon of leadership changes, membership changes, new people coming in. And as that happens, I think this need to continuously, I wouldn't say constantly, continuously be building and ensuring that trusting and safe environment and psychological safety is there for the teams and the team leadership. And I think that's really a good way to think about, that this is not a static point in time, and it's not just a one-time, let's do this exercise and we're done. It's an ongoing exercise and activity. I see some of the teams or some of the members are starting to, participants today are writing in, and we'll go to a poll in a second, but I'd like this kind of feedback. How are you interpreting the results? Monroe says, I'm not sure the question is if OHTs are committed. Monroe is asking a question that I've heard before, is OH, and I think that's Ontario Health, committed to true change? I get the sense that much of this decline may be based on expectations that OHTs would strengthen its support. And that there's a need for policy and leadership and support at the provincial level across all OHTs. And I think that we acknowledge that. We've heard that from a few teams, and so I think there are probably ministry and Ontario Health representatives on these today, and I think that's a good point to be raising. And what are those areas of common support? I think this survey is actually a little bit helpful, as you noted, Ruth, like where are the areas where all teams need similar kinds of supports? And then there are some areas where the supports need to be a little bit more tailored to one or the other. I'll answer in the chat to Ben's question, but we'll be sending out a more fulsome report. We're targeting end of October for that, where we can have item level results. But there is a data package that was shared with the evaluation lead from every OHT. So there are OHT specific results available. Yeah, another thing, and I do want to get to a quick little poll, and then bring Anne on for some of her thoughts and reflections, because I think it's really valuable to have that OHT level view. We're looking at, from the province, a pretty high level. But I was talking with some of the RISE coaches, and Mike Hindmarsh put me onto this, and if Mike's on the call, maybe he can put this into the chat for people, but he recommended this podcast, Brene Brown, on day 2. Brene Brown is an improvement coach working out of the United States, an academic in Texas, and had some really insightful things to say about all of the energy that is there on day 1. And it's easy to really kind of come together, and then people's awareness of what it is that they're setting out to do, and look around and get a better sense of their partnerships. And day 2 is a struggle for everybody. Day 2 is a struggle, and she had many different examples of the way day 2 is a struggle, and I thought that was a little bit of a helpful point, that the only way to come out successfully is to go through day 2. And that is to realize the challenge that's been brought up here, and also to go through the hard work of reimagining, thinking about what it is, and reset. I don't know. Do you have any thoughts on that, Ruth? And then I'll answer some questions, go to a poll, and go on to Anne.
Yeah, I think day 2 is when you have the enthusiasm of filling out the application and getting excited about what you want to achieve together, and then when you get down into the nitty-gritty of it, suddenly the steam starts falling, the shoulders start falling. You realize how much work this is going to take, and the amount of support you're going to need on multiple levels, right, from up above, middle, and ground, grassroots.
Yeah, absolutely. Thanks. Lori is the messiness in the middle of the work. So let's. I want to just get a little pulse on as many people as we can to let us know about your thoughts here. And I'm just going to put this little poll up about whether you're surprised by the results of the survey? Are you very, a little, not very surprised? Maybe you didn't have expectations, so you don't really know what to say about that. And I see we're well over, I got 260 participants today, so hopefully most of people can be in with their vote. A little surprised, not very, and where people are at. I would hope that, I mean, I think some people got to be a little bit surprised because we did ask at the beginning what people's expectations were. And there were a good number of people who were saying it'd be the same or even better. And so some of those people must be a little bit surprised, some of them. Okay, so I'm gonna, seems to have slowed down a little bit for those people who are going to respond. And here's the results out. So only 3% are very surprised. And here's that, 22%, may not have the exact same people responding as the earlier poll, saying a little surprised, half people not surprised, and then, didn't really have a specific expectations. So I think I was around, I probably would have put myself in the bottom bucket. Like there are reasons for me to think both ways, reasons for me to think that I know through the pandemic, many of the teams have really buckled down and gotten together and shared a lot of really positive workings. And then also at the same time, I know that at the time we're doing this survey, people are very tired. And people also starting to look around and maybe say, after that, maybe we have to do a bit of a reset. And so I'm not crazy surprised by these results, but I didn't have a really strong expectation. I think I wasn't entirely sure. Okay, so I'm going to go to Anne, and so Anne, I think you're going to come back on. We'll be able to see you here. And I see a couple last comments before I ask you a couple questions, Anne. And I welcome the people, everybody here participating, because we're all in this together, to continue to chat in and share your thoughts about interpreting the results that we've shared here. And maybe what areas you think will be important for OHTs to support and invigorate. So in your OHTs, what do you think will be an important area? I'm just looking here, a couple last chat points. Fatigue and health and social care partners are feeling on the heels of the past 2 years has impacted commitment to the OHT work. And yeah, the original vision's been hijacked. And I think, your shared vision, people might be like, what is the shared vision now? Is it still the same as it was before? So I think that's a really valid, thank you, Tracy Coffin, for sharing that one in. And Candy says, from LINs to OHTs, part of the lack of momentum, the feeling that the OHTs are operating individually rather than that coordinated group. And I think, moving from LINs to OHTs has increased the heterogeneity and variability in that leadership role in the province. That's for sure. That's a very interesting point. Yeah, don't be too discouraged by the seemingly negative results. I agree, Jason. I am not discouraged. In fact, I think, and I'm going to use the word courage here, because I think everybody needs courage, and I'm encouraged to know that we have 270 something people online today right now, and people are keen and still feel that the work of population health management with the other partners that work together in their areas and improving integration of care is essential. We need to keep moving forward in that way. And I think that's, we're tired, but let's take a little breather, get focused, and advance. And we'll come back to some more of these chats, but I want to get over, Anne, to some questions for you. And I asked you the same question the other day. I said, do you think it'd be better, worse, or and so what would you have expected the results from this survey 1 or 2 years after the candidates? Why don't you share that thought? How did you?
Yeah, sure. And what Walter's mentioning is last week I ran into Walter at U of T, and he told me he was about to send out the leadership survey results, and he asked me if I thought the results had improved, declined, or stayed the same. And it was the same question he just asked everybody in the poll. And my response was that I wouldn't be surprised if they had declined. And Walter asked me why that could be. And so for me, I think there's a couple of main reasons. And I saw some postings in the chat as to why people think that is. And I think there's some good alignment. But the first and most obvious for me is COVID. Like, we're 2.5 years in to the worst global pandemic in a century. So we started out with this sense of shared purpose, and we're all in this together. And now people are exhausted. We've lost resiliency. And when we're working together, we may not be as forgiving in dealing with each other, maybe sometimes a little bit snarky. There's tension. I mean, all of that actually happens when people are working together, but it's that much harder when people are tired. And now, like, we're faced with the aftermath of COVID, the health human resources shortages, the waves of cancer and chronic disease that are coming, the same system challenges we had before, like home care is still there, but now it's even worse. So I kind of feel like we were emerging from a bunker after hurricanes come through. We spent all this time fighting against the hurricane, and now it's passed. We're coming up for air, and then we see this devastation that's all around us, and we have to find that energy to rebuild. And the second reason, I think, in addition to COVID, is exactly what we were talking about earlier, is it's take that day one versus day two. It's taken a couple of years of working together across partners to kind of recognize that creating integrated care across multiple partners is really hard work, and achieving like real collaboration is really hard. We started out, with our OHT applications, this sense of energy and commitment and enthusiasm for change. And the reality is that when we're creating integrated systems of care, it's like, years, if not decades, to actually get where we need to be. And so you need that continuous commitment and resources. And someone mentioned, we need the support from the ministry and Ontario Health and that commitment. So yeah, I mean, fast forward a couple of years after OHTs launched, combined with the pandemic, I'm not surprised that people might feel we've lost our footing a bit. So now is the work ahead to figure out how do we pull together now and push forward to get to that next level.
Yeah. Okay. And I see that. And I think that realization, the view, I'm so encouraged actually that people are really wrapping their arms around this notion that we really need to advance population health too, right? And that is, and there's, thinking about, what the other pieces around, social determinants of health and other things that have been revealed. I think, they were already there for sure, because, people who look at data have been seeing the socioeconomic gradient for quite a while in health outcomes, but made it a little bit more apparent. And the hard work and the people that we need to engage at the close to the front lines and the grassroots, I think it's boots on the ground, and that's a lot of boots on the ground if you have 500,000 people to take care of, and even if you have 100,000 or 200,000 people. Another question I have is, like, after the past few years, now when you're setting out, and we've seen some of these results, and there's so there are many dimensions. Ruth has shown around dimensions in 10 that are kind of part of this conceptualization of the capabilities for integrated care, which align. We've mapped these into the building blocks for Ontario Health teams, and so there's high alignment there. You can't do everything at the same time, and that we've always kind of talked about OHTs as building on some strengths, and then also moving in the directions that were best for them. Maybe just in your OHT, and I don't think this is going to be the same for everyone, if you could say, where you think you might start to reinvigorate that kind of leadership and shared vision. And I don't know if you have thoughts about others and how you even kind of go about deciding on that.
Yeah, we actually, so in East Toronto, started thinking about this last year. And if I think about change and transformation, like, it's not this nice linear trajectory. It's kind of a wiggly line with like hills and valleys. And sometimes you get a plateau, and it seems like progress has slowed down. So last year, our East Toronto leadership team had a conversation about sort of next steps, and kind of the core questions that we asked ourselves are, what's it going to take to get to that next level? And how do we create that energy and acceleration that we need? So what we did is we actually had a third party, we had KPMG come, and we did a review of our governance and structure. And we're now in the process of implementing some changes. This past June, we had all our partners from East Toronto together in a session talking about planning for next steps. And we have a follow-up session that we'll be hosting later in the fall. And in essence, there's two things we're doing together. One is, Walter, what you mentioned is like, what is our next purpose after COVID? It did give us a strong sense of purpose. So now that that's passing, we need to find our new inspirational purpose focused on things like health equity, population health, and for us, our priority neighborhoods in East Toronto. And then The second thing that we're focused on is updating our structure, governance, and how we're organized. And this includes bringing in some new leaders from different partners and more community members to help us with the work. So kind of spreading the load, I guess, and bringing in some new energy that way. So I kind of think of this phase of our work almost like, instead of buying a new house and moving, we're doing some renovations, maybe adding an extension, changing up the color, like just kind of reinvigorating by thinking about like the positive changes that we can make and create some new renewed energy and momentum. And it might be different for others, but just thinking about how we make small changes that can actually just re-energize people.
Yeah, I'll take that house renovation. I know that we were looking at, after living in our kitchen for 2 years, we need a new one for sure. So a couple of the chat comments also coming in. Thanks for that, Anne. And I think some people are actually saying a really nice summary of the contextual factors on the rollout and implementation of OHTs. I think that was really excellent. I appreciate your sharing. A couple of the other comments I'm seeing here are thinking a little bit more about the Ontario Health and the centralized vision. Some people percolating with old stories. Is this going to be any different than Health Links? I'm not sure. I think that might be what you're suggesting there, Veronica. And I think, how do we generate a new conversation that this is actually different? And I think the scale of this is something that's very, very different. And we learned a lot from Health Links, and we have on the HSPN website, because we did some evaluation of Health Links, both quantitative and qual. And I'd recommend you kind of go have a look at some of those, because we definitely learned a number of things from Health Links that we wouldn't want to repeat again here. And I think we are seeing something. So, as an example, just, the importance and prominence of primary care, the importance and prominence of physician engagement are things that are quite different this time around. And so I'd keep the note on that. And also, I think the engagement of patients and caregivers and the primacy of their views this time. We went around and said we were coordinating care for different patient populations, high cost, high needs, in Health Links, and we actually never asked patients or caregivers what they wanted. So I think that's much different this time around. So I think keeping those lessons learned. Some of the others, people talking about sustainability, the importance of that, and I think it's part of Heather's comment here is sustainability is also about a renewal process, right? And I like to think that we don't have, and one of the things, what's our aim is we don't strive for integrated care as a fixed point, but more so integrating care. And I think I don't know, Anne, if you have thoughts or comments on that. And I don't know, Ruth, you worked for many, many years with the Stroke Network. You might have a thought on this too, that we need to think that we have a vision and a goal of where we're getting to, but part of that vision and goal is that we're on a road, and actually even the end point is still a traveling point. I don't know, Anne, and then maybe Ruth, you might add something.
Yeah, it feels a little cliche to say we're on a journey together, but it's true. And I don't know, look at systems around the world, do you ever fully achieve integrated care? It's to me, do you ever fully achieve quality? And I think it's just kind of thinking about the stages of maturity of how we're going to get there.
Yeah. Ruth, how about you? You had to sustain.
Yeah, well, from the days of the Ontario Stroke System, I think the shared vision was very simplistically stated. Fewer strokes and better outcomes, and how the regions got there was individual, but you had that common vision is just simply fewer strokes and better outcomes. And the regions can buy into that. And then, feeding in data to measure and monitor and report and how they're doing was critical, but that common vision just was very simple and non-prescriptive, but yet clear what the goal was.
Yeah, I think amongst the powerful messaging, if you think about brand, and for things to have a brand that people can really identify with, that clear message, is really quite important and compelling. A few other thoughts. Heterogeneity is okay. And I think that's need better engagement between Ontario Health Teams, OH, and the ministry to that kind of broader strategy. And a couple other people agreeing with you there, Ben. Heterogeneity is fine. I think one of the things, and I'll just harken back to the Health Links lessons, is we had 1,000 flowers bloom, but best and promising practices never filtered up because we didn't have that shared space. One of the things we're doing through even today in this event, this webinar, is creating some of this shared space. There are other venues, and I think that's critical and very important to be able to have promising practices. And, there are local collaboratives. There is the RISE collaborative. We have one on performance measurement that runs, and I think OHTs being able to be involved, and they are. I mean, my facilitator is like scrambling to get me to have more people because we are oversubscribed. We can't let everybody in that wants to be, because we do it in a meeting format. And so I think that's really important and a key lesson for us to ensure that there's heterogeneity, but also that those lessons can percolate up and people can see those promising practices. Dean Valentine, I know Dean's participated as a community member supporting OHTs, I think in Downtown East primarily, but he's come on to some of our work, like around our patient experience survey and others. As a community member, I see some of the work so far has given the appearance of 53 different silos. Leadership's in the wait and see happenstance, and OHTs may be waiting for feedback and joint knowledge. And I'll say, I honestly, all of us and Ontario Health and the ministry and the OHTs need to acknowledge that the ministry and OH probably don't want to be overly prescriptive to allow for that local context to bear fruit. And in fact, how things get delivered, the ministry, I think, feels, and I don't speak for the ministry, so caveats on, I can say stuff as a university professor that may not be true, just to get people's opinions. And it might be that they're actually waiting a little bit to see where those promising practices emerge and help to support that, the spread of those. And I think that might be one of the ways to advance that, that there is an overarching vision, but actually how to implement things should be more local. And then there's a role for that shared information and approach. So I think that's the balance of standardization versus local context. And so maybe come to another point, and people continue to please put your thoughts in, reflecting on the results, your own team, where you're at, and we can bring those and share, because this kind of community of sharing and seeing how people react across the province, I think, is really important. We have people from Kenora and Toronto and Ottawa and Windsor, and we don't get to see each other all the time, so it's a good opportunity to share. But I want to say, because Dean here, makes me think, how it's experienced from the patient's perspective. And so, Anne, you're working in one of the OHTs, and OHTs have, a mandate for both patient centered care and citizen engagement. They're not the same things. And this wasn't really covered in our survey, but I think we've had some comments coming from people like Dean. Patients are often advisory to OHTs. There are patient family advisory councils, PFACs, often in name, and yet supposedly part of a tripartite leadership with hospital, community, primary care, and patients quadripartite leadership. Sorry, and patients are interested, like, do they get to help make some of the decisions? How do they feed in? And so what are some of the strategies that you're thinking about in East Toronto, or maybe you have some more general thoughts that you haven't been able to land in East Toronto around strategies to be engaging patients and engaging community, and maybe engagement and then also engagement in decision-making, just to push that point?
Yeah, and I would confess, I think at the beginning of the pandemic, we didn't do a good job of actually engaging patients and caregivers in the strategy work around COVID. It was kind of and maybe other OHTs did, but I don't think that we did that particularly well. It was a bit of an emergency phase. as the pandemic progressed, we got better. But we do have a community advisory committee that's very active, made up of patients, caregivers, and community members. And as we do that structural renewal that I was just mentioning, we are working with our community advisory council to figure out actually how to make sure that we have like strong representation. And I don't just mean 1 or 2 people at every table, but like a number of community patient advisors at every table, including in co-chair roles across the breadth of all of the work that we're doing. And the reason we want to do that, obviously, is to help us stay focused on what matters most to our patients and our communities, and to make sure that we're involving patients as equal partners in the design of the work. But the other thing that, and I know this didn't happen across every OHT, but we were one of the OHTs that received funding from the High Priority Communities Strategy. And so we also thought about how we leverage, and I call them like our community assets. So in our case, we had funding to support the development of community health ambassador roles. We have in East Toronto 5 of our neighborhoods, or five of the 22 high priority neighborhoods for Toronto are in East Toronto. So those are the neighborhoods that were highest hit during COVID. And so we had local residents who, raised their hands to help us as community health ambassadors. So with a small amount of financial support, these were people from local residents who essentially acted as peer outreach workers. They connected us deeply into communities through language and culture. They provided on the ground, like education, outreach, getting people to vaccine and testing centers, helping connect them into financial and social supports. So they basically extended the reach of the traditional health and social care providers deep into communities in need. And like they helped us build a COVID army. And so that was a huge lesson learned for us about how we do that well. And now we're thinking about how do we actually continue to build on that model and leverage these community volunteers and people like residents, leverage them for other things like helping support chronic disease, like diabetes, cancer prevention, and other ways that we can actually promote community health and well-being. I mean, we all look at the health human resources issues. We know we can't possibly meet the demand. We just don't have the capacity for the healthcare and social care pressures we're now seeing. So we're going to have to fully engage our communities in this effort to rebuild and renew. And I think there's also good evidence from the literature from around the world of using this kind of community outreach model. So I think that's something that we need to be doing to kind of help us figure out the future and resource it and figure out how to adopt that kind of model widely. So that would be another way to really engage communities like right on the ground.
Yeah, thanks very much for those ideas. And I think, I'm also seeing, I wonder if people have, had some questions or comments around, OH. I know they have a patient partner leadership. There's the, Patient Family Advisory Council for Ontario that's been on. I wonder if there are, which are the supports that OHTs can lean on, or, which are the supports that can reach out to OHTs around this work. Have you found any provincial, or you just think, this has to be done locally? Yeah, sorry. Do you think it's like a local challenge, or there are provincial supports to help?
So I'm not sure the degree to which we've spread the community health ambassador model. I'm just seeing some comments on the chat. I know a few centers did that. If I look at some of the other places around the world that use it, it's used widely in Africa to reach out around things like vaccinations. Different parts of Europe. I was just talking with a colleague who was doing a study in Italy about how they've used that model. So I think that there's the opportunity to actually think about how we invest in that through sort of public health type funding, and do some of that provincially, and then figure out locally how we tie that into our strategy. So maybe it's a combination of both, like making sure there's resources available provincially, but locally building it into your own strategy.
Yeah, and so I think, if there's other opportunities that people think they're for Ontario Health or the ministry or us actually as the Health System Performance Network to support the teams. I'd be very, very interested to hear you provide feedback. You can contact us. You can put it in the chat here. You can also contact us through oht.evaluation@utoronto.ca. I think, Dipti also thanking Anne around the ambassador model, and the model could be applicable to frail elderly and other subgroups, right? Getting the right people. Jim Hanna saying, thanks to the geography of Northern Ontario. I think there's a different approach. And one of the things I think we still need to be cognizant of in Northern Ontario, again, it needs to be different, is that the geographies are wide, they're dispersed, the resources are not the same, and how do you really reach out into the communities in those remote areas and enable. Thanks, Jessica, for putting a nice little comment in there around some other engagement resources and people sharing in ideas. And Leslie, just right in here now saying digital excellence and health. I think that's at Ontario Health. Happy to support the use of digital assets to support an integrated care team and population health. And I think centralizing Ontario Health is putting out some data packages now, and there's a whole series of them that will be flowing out. Ruth's been one of the people been informed and advising on that work. So we'll start to see, I think, some of more of these centralized resources. We're happy to act as a bit of a compiler of these so that they do get centralized and then and brought forward. I think, digital is one of the things, data enablement is one of the things we might want to standardize across the province. You need to have similar and equal access to data in ways that allow you to deliver new models of care. And we don't want to do that 50 different ways. Not when actually most of the data coming in are quite common and similar across all of the areas and jurisdictions. And I think some other comments in here from Tara, and I think Jim, Barisco, I'm not sure if that's quite right. Really, I think have a very positive spin here. Never lose sight of what we're trying to achieve is better patient experience and outcomes. So let's hope we emerge from the bunker and re-energize. And the time we spent in the last 2 years helped people to get to know each other better and understand our strengths. Continue to do that work, to understand roles and understand what people are bringing to the table, and advance the teams through the strengths-based approach. And I think that that's really, really important and central to the work. So thanks also for those pieces, Anne, around community engagement and patient engagement, because I think that at the forefront is really, really important. I don't know, Anne, if you have anything else you want to close off on, and otherwise I think we might wrap up. We don't have as many panelists on today, so I just want to make sure we had a chance to share this information. And I see there's some more comments coming in, Christine, but I'll get to look at those. But any closing comments, Anne?
Yeah, just a comment, because I think it makes maybe people are trying to figure out how we resource and do all this work. And I think the model that we've really adopted in East Toronto is what I call distributed leadership. So actually trying to figure out how we involve more partners to get them to lead the work. We've specifically not gone to a centralized, like a strong centralized structure. So this is kind of helping us, like partners stepping out to lead the work and doing using their strengths to build different things. Like we have a CHC who's leading the health ambassador work across 4 organizations. That actually hadn't really had anything to do with the OHT at the beginning. We're starting to make it more collaborative now. So just thinking about that, it doesn't all have to be done centrally. You don't always need additional resources either. So that's trying to figure out how we use our resources and assets as we can, because we know there's not going to be a lot more funding coming.
Yeah, it's true. Necessity is the mother of invention. Ruth, any closing comments, or maybe you could let people know about what's final time, but what's coming up for data for them and the kinds of results that we're looking to share?
Sure. Yeah, just to say that we are expecting to get out to the OHTs a very detailed specific report for them. The package was just to give you an early glimpse into what you can expect on the webinar today, but more detail that what cohort 1 and 2 have seen in the past will be coming at the end of October, as well as a provincial report to support that. And as Walter mentioned, you'll have the details at the item level or question level results for your OHT.
Yeah, great. And I see that I think it's an encouraging time. It's probably day 2 for many of the OHTs. Still sort of day 1 for the cohort 3, although you definitely came through that pandemic again, like everybody else. So just a couple other things. We are actually fourth Tuesday of the month. Keep it on your calendars every month. In October, we'll be having an event related to engaging with community. I think that's watch for more information on that. In November, we're coming back to some of our data and population health management, using an example of diabetes management as a way to think about improving care and outcomes. And in January, we are looking forward to having a discussion around network governance, which I know has been on many people's minds. And we've been doing some survey work, some interviews, and we'll have some reports coming out about that a little later in the fall. Just from, we have a tremendous team, and this isn't everybody who's been involved in the work. And we have some new team members that have just joined us in the last few weeks. So you'll start to see their work up here. And just to thank everybody for coming out, sharing with us today. I think today is going to be the one day I don't put up a thank you for providing feedback, because we actually find when we put that out, we get about 7 or 8 of you. There's like 250 people and only 7 or 8 give us comments on this. So we have to find a better strategy of getting feedback on the events. The fact that you show up tells me that you get value, but also looking to the ways that we can enhance and maximize value for you now and into the future. Take care, everyone. Have a lovely afternoon, and I hope you'll be thinking about these results and thinking about how we can use them to advance and accelerate the OHT work with courage.